At the outset, I would like to thank the Endocrinology Society of India for giving me this opportunity to share our experience and my knowledge about this latest, though not so latest now, but yeah, something new that has come up in parathyroid imaging, a 4D CT, advance in a CT scan imaging, just few modification and few extra knowledge and how it accurately helps us identify and pick up the parathyroid gland so accurately and probably better than any other modality that we currently have. So over a period of next 25 minutes or so, what I'm going to do is introduce this 4D CT to all of you so that we are better aware what it is. Operative strategies I'm going to briefly discuss so that we know what is the imaging role and rationale behind 4D CT. We will briefly see some part of anatomy and embryology because that is important, how you should look the CT scan and where all the places you should be looking for when you search for a parathyroid adenoma. Then we'll see the 4D CT protocol that we commonly follow. We'll see the interpretation and diagnosis with many cases. And as we go along, we'll discuss some diagnostic pearls and pitfalls, which we should all be aware to make sure that we don't have any false positive or false negative. And at the last, I'll discuss a reporting template with what the surgeon wants to know and the rationale behind each point. So as we have discussed so far, and we know that primary hyperparathyroidism is a biochemical diagnosis. So the 4D CT is never for the diagnosis. It is not for the sake of the diagnosis of hyperparathyroidism, but for accurately, preoperatively localize the culprit lesion. Because as we know, the surgical excision can offer a definitive cure. And for that to be successful, we need to pinpoint every possible adenoma that might be there so that the surgeon can effectively take all of them out, and hence we can have a curative treatment by surgery. And as we all know, most are single adenoma cases for which minimal invasive surgery can be done. But then there are multiglandular disease also for which bilateral neck exploration may have to be done. And for that, we need to have that information with us prior that, okay, there are more than one lesion that are present or a bilateral lesion which may require a bilateral neck exploration, because as such, that surgery carries much more risk than the minimal invasive surgery. And we'll also know something about the arterial anomalies, which on CT scan we can also see, which will help us to know that there can be a recurrent laryngeal nerve variation or not. So clearly the 4D CT has a superior diagnostic performance. In multiple studies, it has already been proven that in cases where there are non-localizing USG or nuclear medicine study, 4D CT can still help you pick up the lesion. And more so important in multiglandular disease. Like in the previous session also, Dr. Lele also highlighted that when there is a multiglandular disease, the nuclear medicine modalities may not be able to pick all the lesions so well, while it is not a limiting factor as long as the 4D CT is concerned. As many lesions may be present, they all will show the enhancement characteristics and the characteristics that we are going to look for, and will help us say whether there is a single adenoma or multiple adenoma, and if multiple adenoma, how many and where exactly. And of course, in case of recurrent hyperparathyroidism, there is no question to not do this to ensure that nothing was missed in the previous scans. It has got much more better sensitivity than the other test. And that this recent paper clearly compared the diagnostic performance of 4D CT with Sestamibi SPECT CT. And what they found is when you combine the 4D CT with Sestamibi scan, you do not get any additional advantage than the 4D CT alone. So the addition of SPECT Sestamibi is not going to help you localize better in a single disease, and not at all in help you pick up multiglandular disease, which would be anyways done by this 4D CT alone. So what are the operative strategies? Of course, you all are much expert in this than me, but just to briefly tell that the bilateral neck exploration carries a risk. So it is important to localize it accurately if there is a single lesion disease, so that there is bilateral neck exploration is avoided. Both recurrent laryngeal nerves will be at risk. And minimal invasive surgery can be offered if the localization is very accurate and to a single lesion, which is made preoperatively with 4D CT. So where all should you be looking for when you see the 4D CT scan? And for that, we need to know that little bit of anatomy and embryology, that what happens is the superior parathyroid gland arises from the fourth pharyngeal pouch, and they have limited migration. So they are seen relatively in a constant position where they are expected, that is around posterior to the superior pole of the thyroid gland between the cricoid and thyroid. Sometimes it may still fall inferiorly in the retropharyngeal and retroesophageal position, but that's little rare than inferior parathyroid glands, which arises from the third pharyngeal pouch, which is also the site of origin for thymus, which goes as low as in mediastinum. So hence, inferior parathyroid lesion can be relatively commonly found in ectopic locations, especially in as low as in mediastinum, and hence the CT scan covers all this region entirely. It can be found even as high in angle of mandible in carotid sheath, in thymic ligament, mediastinum, or within the thyroid itself. And the 4D CT parameters and various imaging techniques, various imaging findings in this will help you accurately differentiate them for the thyroid lesion. So if you see this frontal view, this red line demonstrates the site where the superior parathyroid lesion can be, while the blue line demonstrates inferior parathyroid lesion, adenoma. You can clearly see on frontal view, it looks like there is a lot of overlap, and as expected, the inferior can go at a much wider range because it has got a longer descent. But if you see the lateral view, you see one characteristic difference. This is the red for superior, which is always posterior to the recurrent laryngeal nerve, that is posterior to the tracheoesophageal groove, if you were to anatomically localize on a CT scan, while inferior gland will be typically anteriorly. And this information will also sometimes help, especially when you are looking at a mediastinal lesion. So the plane of recurrent laryngeal nerve or tracheoesophageal groove really helps to differentiate these two lesions, because we know clearly the higher position doesn't always mean it is a superior gland, and the inferior position doesn't mean it is from the inferior gland. And sometimes the enlarged superior parathyroid gland can descend in the superior mediastinum, what is called as acquired ectopia. And in that cases, it can go as low as in mediastinum, just like inferior. But in that case also, it will be always seen posterior to the tracheoesophageal groove. So whenever you see a lesion in the mediastinum also, you know that it can be still from the superior gland if it is seen posteriorly. And since we are discussing anatomy, just one important point, as long as CT is concerned, is the recurrent laryngeal nerve, because clearly this surgery involves recurrent laryngeal nerve at risk. So when can you have a different or altered anatomy of recurrent laryngeal nerve is in relation to the aberrant subclavian artery. Because as the development is closely related to the subclavian artery and the aortic arch's development, if there is an aberrant right subclavian artery, the right recurrent laryngeal nerve can be altered. And if there is a right aortic arch with an aberrant left subclavian artery, you can have the anomalies of the left recurrent laryngeal nerve course. And what is called as a non-recurrent course can be there, because typically the recurrent laryngeal nerve dips down and then ascends, what is called as a recurrent curve. While in these cases of anomalies, it can have a variable and can have a very variable course, but can be even a horizontal or a non-recurrent course. In this case, they increase the risk of operative injury, because the surgeon will not be expecting it to be at an altered position. So just by giving this additional information of aberrant subclavian arteries, we are also adding value to this preoperative management. So what is 4D? Now 4D, 3D we all are aware. 3D means three-dimensional, is just like any other 3D in the body. It's an axial acquisition of CT scan with coronal and sagittal reconstruction. And as we know, the 3D planar reconstruction helps us localize, pinpoint to any lesion in a particular location. Then what is the 4D? The 4D is the change in the enhancement in the phases. Because we do this a dynamic contrast enhanced study, we obtain, after the plane study, we obtain a RTL and the delayed phase of contrast study. The parathyroid adenoma has a very peculiar enhancement pattern, which is different from the thyroid or a lymph node that may be present in the surrounding, which may confuse us. So it shows typically low attenuation on the plane with peak enhancement in the arterial and washout in the delayed phase of the study. This particular change in the enhancement in the phases is our fourth dimension, which has really added the value for an accurate localization of parathyroid adenoma. So we cover for base to skull to the mediastinum, because just we discussed briefly about the embryology. You can have the lesion as high as in angle of mandible in the carotid sheath or as low in the mediastinum. And then we do the plane study. Now, if you are aware of a dual energy CT, there is something called virtual non-contrast. The dual energy CT, because it can selectively pick up iodine, it can subtract that and give you a plane study from the contrast study, which will be a virtual non-contrast study. While it may be very useful elsewhere in the body to avoid and to eliminate some radiation by not doing a plane CT separately, it may not be so useful in this particular situation of parathyroid edema, because our whole purpose of the plane scan is to make sure that we are able to differentiate from the thyroid lesion, which will appear hyperdense. Now, thyroid is appearing hyperdense because it contains natural iodine. So when you do virtual non-contrast, it will also subtract the iodine from the thyroid gland and make the thyroid gland also hypo. Thereby, you are losing that advantage of differentiating this lesion on the plane study. So hence, we do not recommend this. And some people, by reducing radiation dose, we advise to only cover the only thyroid region, because that is our only purpose of the plane study, to make sure we are sure that it is different from the thyroid gland density. But that is also not going to help you much, because thyroid is our main concern as long as the radiation is concerned. So we end up doing plane in all the patients mostly. And then we do the RTL and delayed phases. This is the protocol. And we take the RTL scan at 25 seconds and then delayed at 80 seconds. Some literature even advocates 30 and 60 seconds, but we have found this more useful as long as the washout picking up is concerned. And we use a little higher KVP because this is the shoulder region which has beam hardening artifacts. And if you have a study with where the artifacts are right in the shoulder region, then it may pass through right the parathyroid lesion and the thyroid region and can seriously hamper the study. So a little higher radiation will help reduce that. And we also use some shoulder lowering maneuvers so that the shoulder is not coming in way. So the image interpretation is the typical lesion, though it is not seen so commonly. But when seen, it is diagnostic of parathyroid adenoma. That is, the lesion will be hypodense on plane. And when we say anything hypodense, hyperenhancing, or washout, it is with relation to the normal thyroid that is present. It will show hyper enhancement on arterial. We will be able to see a differential enhancement from thyroid. And then it will wash out on the delayed phase. And this is the phase where it will be clearly seen separate from the thyroid gland. And it is called a type A enhancement pattern. Now, while this entire spectrum of normal will be seen only on 20%, rest are also not so significantly atypical as long as these characteristics are concerned. It may be little iso-intense to isodense to arterial in arterial phase to the thyroid gland. But in that also you have the plain and delayed phase study telling you it is different from thyroid very clearly. Usually they are oval or rounded, but there can be various shapes like teardrops, discoid, tubular, etc. And the lobulated margins is another finding that may help to differentiate from lymph nodes. You can have, usually they show homogeneous enhancement, but you can have cystic changes, fat, and calcification also may be sometimes present, especially it should alert you for a possibility of carcinoma. One other important imaging finding that is seen on the CT scan is the polar vessel sign. So sometimes despite of all this, if there is a atypical lesion, a polar vessel can really help because parathyroid gland receives supply from the poles, that is the superior inferior poles of the gland. So that's why you may see a polar vessel that is coursing from the pole rather than from the hilum that is seen in the lymph nodes. And we'll see with some of the examples also how it has really helped us in many cases. So let's see some examples. This 46-year-old female presented with hyperparathyroidism and hypercalcemia. So the diagnosis is made biochemically, and the purpose of 4D CT is to accurately localize. And this is how the collectively the 4D CT will look like. You have on the top panel all the axial sections. That is how the CT is acquired. And these are the coronal and sagittal reconstruction in each phases. So the left panel is the plane phase in all the three planes. The middle panel is the arterial phase in all the three planes. And the right panel is the delayed phase in all the three planes. So when you put all these three together, you can accurately localize, diagnose parathyroid adenoma. As you can see, the arterial phase is your money sequence. You can clearly see a very hyper-enhancing lesion, a teardrop-like lesion in this posterior to the right lobe of the thyroid gland, which is seen anterior to the tracheoesophageal groove. So this is most likely to be a superior gland rather than inferior. And you can see the washout characteristic is so well seen that after the contrast administration, after the hyperenhancement, the delayed phase clearly shows significant washout of the contrast. And just to see this on the plane study, this is the thyroid gland with hyperdensity as compared to the muscle or the vessel, or for that matter, even this parathyroid lesion, which we have seen on the arterial phase. It is clearly showing a differential density on the plane study itself, which also tells you that this is not the thyroid tissue. Now, this is what I meant by a dual energy CT. Since we have the scanner, this is not a PET CT image. This is a dual energy scanner image with the iodine overlay. So that will tell you the iodine uptake also so well that in arterial phase, it is iodine uptake is 14.7, which is significantly higher. So it is arterial hyperenhancing, just adds a value to your enhancement characteristic. And this is the PET CT. This patient had a PET CT done a couple of years back for other purpose. And we could obtain it and we could see that there is a FTG uptake also, but the lesion was present already there. One more example of 52 years female. Again, there was a nodule that was found on the left side this time, inferior to the thyroid gland. And as you can see, the arterial enhancement is so clearly distinguished that you can easily pick up the lesion first on the arterial phase. And then we see the plane scan to see whether that is not as hyperdense as thyroid gland to make it different from the thyroid nodule. And then we also see the delayed washout characteristics. Now, sometime, as you can see in this case, the delayed washout is not so convincing visually. But if you put your ROI, you can clearly see that the lesion was 23 HU on plane. The enhancement rise to 103 HU and then fell to 64. So there is a clear washout also. The coronal and sagittal reconstruction there further helps you localize it. One more example, 55-year male, this time with hyperparathyroidism and the proven hyperparathyroidism with negative Sestamibi scan. The scan was negative, and that's why the next patient came for 4D CT to us. And again, this time also you can see the nodule is so very well seen posterior to the right lobe of the thyroid gland. It is clearly hypodense than the normal thyroid gland, showing arterial hyperenhancement. with washout on the delayed phase of the study. And the sagittal phase further help you localize, and it is seen posterior to the tracheoesophageal groove. So this is most likely from the inferior right parathyroid gland. And as you can see, while the Sestamibi was negative for various reasons that we have already discussed in the previous session, the CT doesn't get affected by those factors. The enhancement characteristics are not affected, and therefore the 4D CT could easily pick up and showed a very typical lesion. And this is what I meant by polar vessel signs. So as you can see, this large adenoma showed a did not show a significant hyper enhancement of arterial phase, a type B type of enhancement, and hence leaving us with a little doubt whether it can be parathyroid adenoma or not. But as you can clearly see, there is a polar vessel sign. The vessel is anterioring the superior pole, and this sign really helps us to differentiate from any lymph node that may be present. So this is another parathyroid adenoma, large elongated with a polar vessel sign that is seen. These are from literature also, which shows even such typical lesions, such large elongated lesion will also show such typical polar vessel, and that adds to the diagnostic value. So now this was all about the typical. What are the atypical features? Like I said, there might be some iso enhancement to the thyroid gland or arterial. Now remember, on arterial phase, the thyroid itself also enhances brilliantly. So this doesn't really take away significantly from us the diagnostic confidence that we have, because the washout on the delayed phase will be clearly different from thyroid even in this lesion. So putting this two together, we see the majority of parathyroid adenoma are easily diagnosed on 4D CT because of this washout, and also the hyperdensity on the plain study of normal thyroid is missing in parathyroid adenoma. Only very few percentage of patients shows type C enhancement, where it is iso enhancing to the thyroid gland both in the arterial and delayed phase, what is called type C pattern. Here also, most of the time, the thyroid will be hyperdense to the nodule. The nodule will be seen separately, at least on the plain study. The only challenge in this type of small percentage of patient with atypical presentation type C enhancement would be if the thyroid is also compromised, if there is, say, hypoparathyroidism due to thyroiditis or any other cause, and if thyroid has also lost its density, then this will be exit isodense to the thyroid. But this forms a really small percentage of cases. So this is what one example of type D enhancement is. There was a large elongated lesion in the right paraesophageal region. As you can see, it is posterior to the tracheoesophageal groove. So despite being such low position in the mediastinum, this is most likely to be a superior gland. And you can see the enhancement is not that avid on arterial phase, but clearly on the plane, though I am not showing this only small part of thyroid you can appreciate, it is clearly hypo to the thyroid, and the delayed you can appreciate washout that is differential from thyroid. So this was about type B. So collectively, this forms the majority of cases, and putting all these characteristics together along with the hyperdensity on plane with polar vessel sign, practically we will never be able to miss a diagnosis of parathyroid adenoma. So what about parathyroid carcinoma? Now this is something on radiology will not be so clearly evident. There are some clinical clues like younger age of the patient with markedly elevated parathyroid levels, but the only sign that is been described is a relatively more common of presence of calcification in these lesions. Apart from that, this lesion will not appear so aggressively different like elsewhere in the body where you can differentiate carcinoma from adenoma. But as in this patient, this is a 26 years female, a young female who presented with a markedly elevated hyperparathyroid levels, hyperparathyroidism. So in this case, we found these findings. On the plain study, there were small speck of calcification, a relatively large lesion than what we see commonly. Even there are some necrotic and cystic changes. But apart from that, it showed the similar enhancement characteristic and the dynamic changes as in adenoma. But we could suspect, and I think it did turn out to be carcinoma, though I don't have a histopathological diagnosis, but had a word with the endocrinologist. And these are the common ectopic locations that we find in retropharyngeal for the superior gland within the thyroid itself. But like you can clearly see in all phases, it will show differential density and enhancement from thyroid, even in the mediastinum, as we saw a couple of examples, and even in carotid sheaths. This is one such location where you should always look when you don't find anywhere else, or even if you find elsewhere, just to make sure that you are not dealing with multiglandular disease, is the carotid sheath, which is common, which is sometimes missed and can lead to unsuccessful surgery. So multiple glandular disease can be even present in the parathyroid glands itself in the ectopic location. Like in this case, if you find this lesion in the on the left side in the superior gland region where there is arterial enhancement with washout, and if you stop there that you have found your lesion, you have found your answer, you will miss this multiglandular disease because there was a lesion for the inferior gland also in the same patient. And this is how the hyperplasia will look like. It will show all the 4 glands showing almost uniform enlargement and enhancement. Another example of multiglandular disease of our case, where we saw that even the superior and inferior glands were lying close to each other. And we could clearly see there are 2 nodules, but both showing similar enhancement characteristic different from the thyroid gland. And we could make the diagnosis of multiglandular parathyroid adenoma. So this was all about our cases that showed where that helps us. As you can see, you can make the diagnosis very confidently on 4DCT. And the mimics are the thyroid lesions because it is in the close proximity to the parathyroid gland. But like I said, it will show hyperdensity on plane. Only caveat is if there is a hyperparathyroidism, then this point will not hold true. But in those cases also, the enhanced differential enhancement will help you. The polar sign, vessel sign will help you. Then it is isodense to iso enhancement to the rest of the thyroid. And USG also may add to a value sometime because the parathyroid adenoma is usually hypoechoic while the thyroid gland is hyperechoic. So let's see this example. This 49 years female who presented with hyperparathyroidism, and there were equivocal result on the nuclear medicine scan. And that is what happened here. When we first saw this scan, we found a nodule here, which is arterial hyperenhancing. But as we went to the plain scan, it showed similar high density to the thyroid gland and similar washout to the thyroid gland. So as you can see, it all the time, it matches the density and the enhancement with the thyroid gland. And hence we knew that this is not the lesion that we are looking at. And just when we thought that we are looking at maybe a negative scan, we found another lesion low down in the mediastinum, which is actually showing typical parathyroid adenoma characteristic. It was hypodense on the plane, showed arterial hyperenhancement and washout. And like I said, if you have any doubt, you can always put ROI and you can clearly see that there is a significant hyperenhancement to 80 HU and which washed out to less than 30 HU, clearly demonstrating the typical enhancement characteristics. This is one more female, 44 years with hyperparathyroidism with USG suggestive of bilateral parathyroid adenoma. So then once we saw the CT scan, we also found a bilateral lesion. But while the USG could not further discriminate whether there are both parathyroid adenoma or not, CT scan clearly gave this discrimination. So as you can see, there is a large hypodense nodule posterior to the left lobe of the thyroid gland, showing arterial hyperenhancement with a clear washout on the delayed phase. Even your 3D reconstructions give you the exact localization and enhancement, suggestive of parathyroid adenoma on the left side clearly. But what about the right lesion? While you see hypodensity, okay, this may still be parathyroid adenoma because it is not showing the thyroid density. This shows arterial hyperenhancement clearly more than the thyroid gland. So this can still be parathyroid adenoma with some heterogeneity. And we know that some heterogeneous enhancement or cystic or necrosis can happen. But what happens on delayed study? There is no washout. This is one stage that tells you that this lesion is not a parathyroid adenoma. And this did turn out to be the patient could undergo both surgeries together, left for parathyroid adenoma and right for this thyroid lesion. And this turned out to be a thyroid lesion, thyroid nodule, while the left was parathyroid adenoma. And there was drop in the parathyroid level also just after the removing of the first gland on the left side. So like I said, putting every findings together, CT scan will practically give you answer in all the situations. Lymph node is another mimic, but they are also hypodense on plain studies, but they show progressive enhancement. They will not show washout on the delayed. And also additional characteristics of lymph node like fatty hilum and a hilar blood supply rather than polar that we discussed can help you differentiate them. So when you see a 4D CT, how you should be systematically looking at the scan to first ensure you pick up a lesion. Secondly, you don't miss multiglandular disease. And third, you don't make a false positive diagnosis is to see first you look for the arterial phase. Because like I said, there will be arterial hypermanagement, which will make them more conspicuous than any other phase. So first scan should be arterial phase. And where you should look for at all the ectopic location where you would expect a parathyroid gland to be. And that may also show you a lesion if present. Then next is to see the arterial phase only, but in ectopic location from the skull base to the mediastinum to see if there are any ectopically located lesion or additional lesion. Then you compare with other phases once you have localized to ensure that you are dealing with a parathyroid adenoma and not other arterial hyperenhancing lesion like thyroid lesion. And then you see for another morphological characteristics like lobulation, polar vessels, and etc. that will help you differentiate from lymph node. And finally, we also see the other modalities and history to make a correlative diagnosis. So again, to highlight this paper, they clearly showed that in this case, they found this parathyroid adenoma pathologically proven, while in Sestamibi, it did not show it. It showed a false negative result. So but the important part is they compared all the patients done both, the arm study had done both 4D CT with the Sestamibi scan, while the control study had only Sestamibi scan, and they did not find any significant difference, only 4D CT scan. So to conclude, this is the reporting template we follow to make sure that we have mentioned all the findings that the surgeon needs to know as a part of preoperative workup for this 4D CT. Is first, identify the number of candidate lesions. Single lesion favors adenoma with minimal invasive surgery can be offered. while multiple lesion may require bilateral neck excision. The size of the lesion, because a smaller lesion, even if we don't find additional lesion, there is a high chance of multiglandular disease. So a small single lesion should always alert you to look for many more, if there is any more lesion. Lesion location has to be described with the respect of surgical landmarks, because usually the radiologists try to give it with the vertebral level, C7, T1, etc. That is not the surgical landmark which the surgeon is going to see intraoperatively. So we try to describe the lesions with respect to the surgical landmarks like cricoid cartilage, tracheoesophageal groove, thyroid gland itself, and the suprasternal notch, which can be easily correlated intraoperatively. The opinion and confidence level of the radiologist is important. Like I showed some of the atypical examples, then you have to say that so that the surgeon may start with a minimal invasive surgery and do the candidate lesion surgery first, and then check for intraoperative parathyroid level. If it has not dropped, then he might have to convert it to a bilateral neck exploration and look for other lesions also that were not so confidently picked up. Then you look for ectopic and we mentioned ectopic and supernumerary parathyroid gland. Then you also concurrent thyroid lesion also we described, like I showed in the last example, that may require a separate thyroid workup also, but the advantages both can be taken care in a single surgery. And then we also mentioned the arterial anomalies is present, because like I said, there may be a aberrant subclavian artery which may lead to a anomalous recurrent laryngeal cause, what is called as a non-recurrent cause, and that might lead to a surgical complication if there is a non-recurrent cause. So these are all my references, and thank you for your attention. I hope this has made clear about the 4DCT, its role, and the advantages that it has.